Welcome to Broad Eye, the podcast that explores knowledge gaps in ophthalmology and eye care. Hello and welcome to another episode of the Broad Eye podcast. My name is Sean Maloney and I am here today with my good friend and co-host, Dr. Bruno Fernandez. Bruno, how are you doing today?
I'm doing good, Sean. Thanks for asking. We do have another friend, right, today?
That's it. We're going to be going back to some of our roots here. Both of us have worked with, for many years with our guest today, Dr. Julie Burnier. Julie, I'm going to call her Julie moving forward. That's how she was before she was Dr. Julie. We knew her as Julie. Dr. Julie Burnier is an assistant professor at McGill University in the departments of Oncology and Pathology, and she's a research scientist at the Research Institute of the McGill University Health Center. Julie, thanks for joining us today.
Thanks for having me, guys.
Great. So this conversation is going to dive into a topic that probably a lot of listeners are not that familiar with. So I thought we could maybe start with a high-level overview of liquid biopsies. If you could explain a little bit, what is a liquid biopsy?
Sure. So a liquid biopsy really is the sampling and analysis of non-solid biological tissue. So what does that mean? Those are the biofluids that we find in our bodies. When we talk about liquid biopsy, we primarily talk about blood, but it's not just blood. We can talk about saliva, we can talk about urine, cerebral spinal fluid. All the different biofluids that we have in our body are rich sources of material that comes from our bodies, but also from diseases that can inflict us, such as cancer. And as a cancer biologist, I look at liquid biopsy from the perspective of a tool to diagnose and monitor cancer patients.
And what can you detect in a liquid biopsy, like cells, molecules, markers? It's like what exactly you're searching for when we study those?
Well, we can find a lot of different things. So in cancer, we really look for what we call circulating cancer cells or circulating tumor cells, which are cells that detach from the primary mass, the primary tumor, and enter the bloodstream. And we know that those cells are the cells that are largely responsible for the spread of cancer in somebody's body, for the process of metastasis. And so we can identify those cells based on the properties of those cells, and it allows us to monitor patients, but it also allows us to really study their disease. The other thing that we look for in recent years, and is a big focus of my work, is looking for genetic material in the blood. So we already do that for other non-disease states, like, for example, for prenatal testing. So pregnant women in Quebec have access to prenatal testing, and that's where we look for cell-free pieces of DNA that comes from the fetus in the maternal blood, and you can screen for all sorts of different disorders. So much in the same way, in a patient with cancer, we look for pieces of their genetic material that comes from the tumor, and we term that circulating tumor DNA.
Okay, so if you're looking at, let's say you're looking at the blood, for example, of a patient, what are some of the benefits of doing a liquid biopsy versus a traditional, tumor biopsy in this case?
Yeah, so there's a lot of benefits. The big one is that it's a really minimally invasive approach. So if you think about doing a biopsy on a patient, a traditional biopsy versus taking a blood draw, we know that it really, it's much less invasive, and it provides the patient through treatment a much better quality of life if they're being monitored in this minimally or non-invasive way. For patients with cancers in the mouth, for example, we've started looking at saliva. So that's just spitting into a tube. We don't have to, it's a complement to having to biopsy different tumors. So it provides us a much easier, less expensive, and much better for the patient way to study and monitor their disease.
And how do you process a liquid biopsy sample? Do you spin it down and put it under the microscope, or is there any other way of getting you the answer that you're looking for?
Yeah, it always starts with spinning. We're always spinning down the blood to get rid of all the cells that are just the normal parts of the blood, your red blood cells, your white blood cells. And then we're really looking in different ways to isolate the material that we're looking for. If we're isolating cancer cells in the blood, for example, then we're using systems that allow us to look at the shape and the size of cells and isolate the cancer ones based on the characteristics of the cancer cells. If we're looking for DNA, then there's commercially available kits. There's lab techniques that we use to be able to really isolate, to distinguish the DNA that's coming from tumor cells versus the DNA that you would find for other reasons in the blood, like, for example, coming from your blood cells or coming from normal cells in the body. So there's a lot of, kind of molecular biology techniques that we use routinely in the lab to do that.
I was just going to jump in with a quick question here, if you don't mind, before you keep going there, Bruno. When you're talking about detecting tumor cells, detecting DNA, can you, I'm thinking about someone just going for a routine blood test. Can you use this concept of liquid biopsies to maybe detect certain diseases, or in your case as an oncology researcher, certain cancers before maybe other types of scans or what have you?
Yeah, it's a good question. There's a lot of work going into seeing whether we can use it as a diagnostic tool. Liquid biopsy really in the cancer space is being used. Okay, so can we use it to diagnose diseases, to really kind of screen for patients that could have a disease, much like you do a pap smear, for example, for women to look for cervical cancer? Can we do that non-invasively for patients? And there is a lot of work to suggest that in certain contexts, that is the case. We can look for pieces of DNA that would indicate or would indicate a malignancy, a cancer, as a screening tool. What we do always have to balance is whether the disease has a prevalence that would allow for us to screen in that way, the cost effectiveness of such a tool. The other really big field for liquid biopsy that I'm really excited about is a way to monitor patients that already have the diagnosis of cancer. So if a patient is already diagnosed with a specific cancer and are undergoing treatment, I think liquid biopsy can provide a lot of exciting potential to monitor these patients in a non-invasive way. We know that when patients, for example, are on chemotherapy or radiation therapy or undergoing surgery, every additional invasive procedure that we do can be quite difficult for those patients. They're already going through a lot. Their bodies are going through a lot. So if we can monitor in such a personalized way and non-invasively, then I think it really helps us keep a close eye on the disease in a way that's good for the quality of the life of the patient.
And sorry, might be a very basic question here, but is it when you send one of those biopsies to the lab, do you need to know what you're looking for, and do you get like a yes or no answer? I'll give an example here to illustrate. Let's say if you have a blood test from a patient that had uveal melanoma and you want to know if there are any circulating cells. Is it possible, for example, to kind of oh, you don't have any uveal melanoma cells, but we found a prostate cancer cell? Can you look for one thing and find another?
I mean, you could, and I think it's a question that we're still really trying to get an answer for. Bruno, you might remember from your days in medicine that sometimes we do have patients with multiple malignancies too, right? Yeah. And sometimes we want to know what's contributing to their disease. And so in certain contexts, liquid biopsy can allow us to see, okay, we do see something in the blood, where is it coming from, and help us to diagnose what cancer is causing, whether it's symptoms or disease progression. I think it's important to note that this is all really kind of in the research phase, and we're learning every day about what liquid biopsy can show us as a tool for diagnosis, as a tool for monitoring, as a tool for finding out that yes or no, if the patient has cancer or doesn't have cancer. We have some exciting projects right now in the lab where we do think that in some cancers like ocular melanoma, we might have a test that tells us if a patient has a tumor or not. But it's all being developed, and we need to run the right clinical trials and the right clinical studies to be able to validate and really for sure show the benefits. But I think what's becoming clear to me and our group and many groups around the world is that there's so much potential for liquid biopsy as a tool in medicine, in personalized medicine, and to help us really track these patients and provide them the best care.
So Julie, okay, you dropped the word in there, and so did Bruno. You mentioned ocular melanoma, and Bruno mentioned uveal melanoma. Maybe just for the audience, for some people who'd be listening, they wouldn't be that familiar with those terms because ocular melanomas or uveal melanomas are quite rare in general. Can you maybe just explain a little bit about what these tumors are, and maybe if you have an idea of who they affect or incidence, anything like that?
Yeah, sure. So uveal melanoma is the most common intraocular tumor in adults. So it's the most common tumor that you find inside the eye of adult patients. And it's quite a rare disease. We're looking at about 5 per million in incidence. The incidence does reflect a little bit where the person lives, eye color, kind of like melanoma of the skin. So uveal melanoma is a disease that arises inside the eye in something called the uveal tract. And I like to talk about it in its comparison to cutaneous melanoma, to skin melanoma, which is the most lethal form of skin cancer, because most people are more aware of skin melanoma than they are of ocular melanoma. So uveal melanoma comes from the same cells that cause skin melanoma, but these cells are found inside the eye. And while skin melanoma has, kind of another way of arising, they don't present with symptoms, and their disease, their cancer, their intraocular cancer is diagnosed during a routine eye exam. And that's really important because while uveal melanoma is very rare, it's quite a deadly disease, with 50% of patients having advanced diseases at some point during their disease course, and developing metastasis or their cancer spreading to other organs. So it's a disease that, while it's rare, it's really important for us to study and to treat appropriately because it's associated with a high mortality rate.
So it's cool you mentioned it, because I think like melanoma is the #1 mortality cause in the ophthalmology field, even though it's rare.
Yeah.
There's no other eye disease that kill as much, even though like we don't have a ton of melanoma patients.
Well, that's right. So it's it doesn't have a high prevalence like some other forms of cancer, like prostate cancer or even skin cancer, but it does kill a lot of patients, and we need to study it better, and we need to understand the disease so that we can monitor these patients very carefully.
Julie, so when we're talking a little bit about these ocular tumors and talking about blood samples, you mentioned at the very beginning of this conversation about when describing what liquid biopsy is, that it really, you can take a liquid biopsy from cerebrospinal fluid, from urine, from different bodily fluids. Why the blood for this type of disease, and what would be some of the other indications? Like, when would you ever take liquid biopsy from urine or from cerebrospinal fluid versus blood? When would it be beneficial, or is it disease specific?
The way that we do it in the lab is that we try to really think about what makes sense from an autonomy point of view. So, what is the anatomy of the disease? What organ does it affect? So we know that uveal melanoma is a disease, like I said, that spreads in half of the patients that it affects. And it spreads through the blood. We know that because there's no lymphatics in the eye, so it has to spread through the bloodstream. And so blood seemed to us like a really good choice for us to study the presence of molecules or cells or DNA that comes from those tumors in the eye. And what we found is that really that is the case. In the lab, we are looking at some other forms of liquid biopsy in uveal melanoma. For example, the aqueous humor, which for those that don't know, is the fluid that you can find inside the eye. And we're looking at that because sometimes to decrease eye pressure, that fluid is removed by an ophthalmologist and discarded. And so we're looking to see if we can kind of recycle that fluid to help us study and diagnose uveal melanoma. But what we are seeing is that in terms of the blood, in all of the patients that we've tested for uveal melanoma DNA in their blood, we are able to find it, we are able to detect it. And that has really important implications. It's important because it allows us to study the disease. It's important because we can monitor the levels of that, kind of like a biomarker. And it's really bringing us a step closer to understanding how this disease spreads.
So we all know that your lab is one of the most active in the world, like in the uveal melanoma research. Can you give us like a sneak peek of what's going on, like the latest research that you've been involved on, and the things that you should be excited about?
Yeah, sure. I think we have a few cool projects right now in the works. In the uveal melanoma space, we're showing that fragments of DNA that are released by tumor cells in those ocular tumors, in those ocular cancers, can be found in the blood. And we see a really strong correlation between the levels of those molecules, those pieces of DNA that come from cancer cells, with the level of disease. So we're really excited about that. We're really excited about it from two perspectives, as a way to diagnose small tumors. As Bruno probably remembers, the diagnosis of a small melanoma can be sometimes a little bit tricky. And one of the reasons it can be tricky is because, like skin melanoma, some ocular melanomas come first as a nevus. So if we think about, nevi are those moles that you find on your skin, for example. Well, we also have moles inside of our eye. And we just don't see them as often because nobody's really looking inside their eyes for those types of things, but sometimes the ophthalmologist will see them. And we know that a percentage of those eye moles, let's say, those nevus, can develop into melanoma, and we know how deadly ocular melanoma can be. So while in the skin, you would one day just see that you have a new mole, and you might go to the dermatologist and ask, okay, does this look suspicious? And then just monitor it over time. It's a little bit more tricky when we're looking at it inside the eye. So we're really excited to see that liquid biopsy might help us be able to differentiate or to be able to catch those moles turning into cancer. So we're really excited about the project from that perspective. And then we're really excited about the project to give us a way to monitor these patients. We talk about the non-invasive nature of a blood draw, especially compared to a traditional biopsy. But a traditional biopsy of the skin is one thing, but a traditional biopsy intraocular is another. And I think probably anybody listening can imagine that you don't, necessarily want an intraocular biopsy if you can help it. So I think liquid biopsy gives us a really great advantage in that sense of being able to monitor patients in a way that's much less invasive. So we're really excited about that work.
So, I know all three of us on this conversation know a little bit about the history of the lab that you're running. There's a strong history there of ocular melanoma research. What I always found interesting is you had, branched out. Before you came back to this lab, you had a lot of, cancer biology, molecular biology training, and then brought all that expertise back to this lab that you're now the superstar at, putting it very mildly. I'm just curious, in some of your other training, did you specifically study liquid biopsies in other ways before you took that expertise back to the ocular oncology world? Or, what was some of the background that you had that led you to look at liquid biopsies as a research domain or a research angle in this field?
Yeah, so I definitely don't feel like a superstar, but thanks, John. No, I think it's it's funny how life leads us to different paths, and it's definitely led me back into a field that I wouldn't have predicted necessarily that I would be in. I'm a cancer biologist by training. I did my PhD at McGill. I did it in liver metastasis research, and liver metastasis is when cancer spreads to the liver. and that can be quite a severe outcome. And it's a part of cancer biology that I was really interested in, trying to understand how we can understand the spread of cancer to the liver and stop it. And I wasn't working in uveal melanoma. I was working in something else. I was working in a different type of cancer called colorectal carcinoma. And I needed a model to validate some of my findings during my PhD. And as you know, Sean, my father's an ophthalmologist and has a big lab working in ocular diseases. And so I teamed up with him to see if we could validate our findings. And I got really interested in uveal melanoma. It's a rare disease, but has a high mortality rate. It's a really, from a biology perspective, a really unique disease, and that we really do need to understand it better. There is a need there for us to treat patients in a more personalized way, to understand the disease, to understand why some patients live with it for a really long time and some patients develop that spread. So I got kind of really excited about studying it and trying to make an impact for cancer patients. And then, as you said, I went away and did all sorts of postdoctoral training abroad, again in the cancer field, and in Toronto worked in ovarian cancer, and got really excited about liquid biopsy and the potential of liquid biopsy for ovarian cancer and other gynecological cancers. And so when I came back to McGill, I focused my research on how we can use liquid biopsy as a tool to monitor different cancers. And as you know, I work in a lot of different cancers, not just uveal melanoma, but I think I've always held on to that, that I guess desire to understand uveal melanoma and to try to make a difference in this field. So yeah, so that's why I kind of always come back to this disease and hope that our research leads to something, which I think it will, something promising and that will benefit the patients that are unfortunately inflicted by it.
And you mentioned already that the use of liquid biopsies in the context of oncology, it's still considered research. Is there any estimate on when it's going to be available, like commercially or like in a clinical setting, like so as a real tool, like to guide the clinical decisions?
What's really exciting, I think, is that in some specific context, liquid biopsy is already in the clinic. So the FDA approved, I guess it's now maybe 5 years ago, if I'm not mistaken, the EGFR. It's a mutation that happens in non-small cell lung cancer. And so they approved this liquid biopsy test called the COBIS, and it tracks this particular mutation in patients with non-small cell lung cancer. So we know that the potential is there. And I think that's really exciting for the liquid biopsy enthusiasts like me and the community in general. I think there's work for us to do in each specific context, in each specific cancer type, to bring it to the clinic, to bring it closer to patients. When we talk about uveal melanoma, one of the challenges that we face is that it is a rare disease. So for the listeners, now especially during the pandemic, everybody knows that oftentimes it takes a really long time for us to develop pharmaceuticals, treatments, new tests, and with unprecedented speed, we were able to come up with vaccines for this pandemic. But that was really because of how many people have been affected by COVID and its high prevalence rate. When we look at a disease that has such a low prevalence, when it has such it doesn't inflict that many people, it's rare. For us to be able to accumulate the data necessary to be able to validate our findings, to prove, this test works, it's challenging. So one of the things that we're really excited about in the lab is that our liquid biopsy studies in uveal melanoma are highly collaborative. We're working with groups all over the world so that we can have as many patients as possible enrolled on our studies, so that we can, as quickly as possible, determine if this is something that we can bring to the clinic. So we're working with labs and hospital centers in the US, in South America, in Canada, at Université de Montréal. So we're really trying to, work together because there aren't that many patients in one particular geographic region. We have to work together. We have to bring these patients together, these samples together, so that we can really make an impact.
So you touched on personalized medicine, and maybe we can use that as I want to circle back to that before we let you get back to the good research that you're doing. Why is personalized medicine such a hot topic, I guess, nowadays? Like I've seen it, that terminology used not just in dealing with ocular tumors, but when looking at many other diseases, I guess. And it just seems to be something in the last 5-10 years you hear people referring to a lot. So what would be your, I don't know, best stab at why personalized medicine is so important, and maybe why that is the case in for ocular tumors as well?
So personalized medicine is definitely one of those buzzwords that we're hearing all the time. And I think in a way it's, it's definitely become a buzzword, but in another way it's really important. As a cancer biologist, intimately aware of how complex cancer is, sometimes we tend to think of cancer in quite a simplistic view, right? Okay, there's cancer cells, we'll kill them and that's it. But we know it's a lot more complicated than that. Each tumor, each cancer type, whether we're talking about ovarian cancer, prostate cancer, breast cancer, leukemias, ocular tumors, they're all really different. Their biology is different from one another. And then from patient to patient, those diseases are really different. The breast cancer that one patient might have is quite different than the breast cancer that another patient has. That because nowadays we have these amazing methodologies, this amazing equipment and infrastructure to really analyze the genetic components of cancer cells and really characterize them. And so the more that we've done that, the more questions it's raised and shown us how complex and how varied and how heterogeneous these cancers can be. And then on top of that, each person's immune system is different. So each person's ability to fight off cancer is different. So that's of course going to impact their ability to receive different treatments, their ability to tolerate different treatments. So, gone are the days where we used to just give the same medicine to, everybody who walked in the clinic. We're really moving towards a personalized approach. We already see that in therapeutics. We already see that nowadays we have really great specific treatments that target whether it's a specific mutation that a patient might have in their cancer cells, or a receptor on their cancer cells that is overly active. We now know that there's a lot of approved and in clinical trial drugs that can be really helpful to specific patients, but maybe not to another group of patients. So our cancer world is already really moving to a more personalized view, and I think that's really important. In oncology, we call that precision oncology. It's another buzzword, but I think it's important for us to keep that in mind and to know that if we can start thinking about patients, and their disease as a really individualist, in a really individual way, we might be able to find the right treatments and the right way to monitor and track their disease that best works for that particular treatment. So it's, we might not be completely in personalized medicine yet, but there are definitely lots of signs showing that we're getting there. And the more research that we do, the better. When we talk about uveal melanoma, it's a disease where sometimes we don't understand why one patient has a uveal melanoma tumor and they never end up having any spread, and they never end up having any problems down the road. And another patient might develop, might have their cancer spread to other organs and unfortunately succumb to their disease. And so, yes, we're learning that there's different proteins that are expressed and different mutations that might impact that. So we're starting to learn that we can characterize people's diseases in a really personalized way. So we can say, okay, patient A might need one sort of treatment, but patient B might benefit from a different approach. So I think that's where we are, and it's actually a really exciting time to be in the field. And I think in the next, I can't give a timeline, but in the foreseeable future, we're going to just bring that personalized approach more and more to the clinic.
It sounds like what you're doing. Now we've kind of come full circle in the conversation, because it sounds like liquid biopsy is one of the, I would say, most formidable tools in personalized medicine, right? You can gain insights into the, in this case, in looking at ocular tumors, you can gain insights into the biology of those tumors without ever touching them, and determine maybe what the best course of action is. And even over time, as someone's being treated, still have a minimally invasive way to monitor that treatment, and if you need to, adjust course along the way. So, Julia, this is awesome. This is an interesting conversation. I know I've actually learned a lot. I probably should have known all this before, but I've been out of research for a while now. And Bruno, I'm sure you remember, you know all this, right? This is all nothing's new for you.
Well, I mean, a lot of things have changed, man. Like, I mean, since my days in the lab, but like, I mean, I'm glad that Julie here was able to tackle such a like, I mean, niche theme and put it in terms that was very easy to understand. Thank you.
And that concludes today's episode of the Broad Eye Podcast. If you enjoyed this episode, please be sure to subscribe on your favorite podcast platform. Of course, ratings and reviews are always welcome. And you can certainly share this episode with any of your colleagues or friends who might enjoy it. Thanks for listening.